to move on now to elbow, hand, and wrist problems. And so we are very excited to have a different speaker for this. And this will be Dr. Nico Lee, who has been with us since 2013 here at UCSF. He is the medical director of orthopedic services at Zuckerberg, San Francisco General Hospital, and the chief of orthopedic hand and upper extremity at Zuckerberg, and the program director here at UCSF for hand and upper extremity fellowship. Dr. Lee works in upper extremity elective and trauma care, and he works from fingertip to shoulder. He is also interested in soft tissue coverage and microvascular surgery. He went to UCLA for his bachelor's and master's degree, and then did medical school there as well, and orthopedic surgery residency at Baylor College in Houston, Texas. He then did an upper extremity surgery specialization fellowship with an emphasis in microsurgery at the Medical College of Wisconsin, and combined plastic surgery which was a combined plastic orthopedic surgery program. And so we're very happy to have him here. He's going to speak to us about common problems that we will see in the office: shoulder, hand, and elbow, hand, and wrist. And then we will also mic him up and take him to the room, and he'll do some demonstrations on our wonderful models and show you how to examine those joints. At the end, I will keep him there in the center where he is doing the exams, and I will take questions and field them to him. If you have questions about things you'd like repeated from the exam that he's showing you, or questions of his talk, we'll field them at the end of the two sessions. Okay, so Dr. Lee, we're ready to take it away.
All right. Hi, good morning. Thank you for the introduction. I appreciate that. So today I'm going to talk about common hand, wrist, and elbow problems and how to spot them in clinic. I made a hybrid presentation where I actually have physical exam videos in my slides, because sometimes it's hard to demonstrate in a live patient virtually some of these exam findings. So I do have videos embedded. And so my talk is going to be about 40 minutes, and then about 15 minutes for my live physical exam, which I will redo the exam videos that I am showing you in these slides. I don't have any disclosures. So I wanted to start anatomically, starting from distal to proximal. Some of the common findings some of the more common more common pathologies we see in clinic. And also some don't miss injuries that I would like to discuss, such as the Jersey finger. So starting with the mucous cyst, this is how the patients will present. A mucous cyst is a ganglion cyst of the DIP joint. And depending on the location of the ganglion cyst, they may or may not have some changes in terms of their nail. If you look at the picture with the nail deformity, the cyst is closer to the epinicial fold, and that's where you have the germinal matrix, which is the producers of the cells that produce the nails. And if you have a pressure phenomenon there, then you would have nail dystrophies. The picture on the left, on my left, actually the cyst is more proximal. It's further away from the germinal matrix, and therefore they don't tend to have nail deformities. For these patients, when they come to my clinic, I get an X-ray just to make sure that I am looking for osteophyte, and to also see how arthritic their joint is. So how do you treat this? Some patients will try to needle it themselves, which I don't recommend. I also don't recommend practitioners needling it. There is high recurrence risk and approximately a 5% infection risk. Sometimes these infections can become osteomyelitis, which I've seen, and so I usually don't recommend aspiration or needling. For us, treatment for the mucous cyst is surgical, and the key is not so much taking out the cyst, is actually debriding the osteophyte. If they do have arthritis and they have pain with motion and they have a mucous cyst, treatment for that would be a DIP joint fusion instead of just debridement of the osteophyte. The other question I get from patients is, what about the nail? Would this get better if I treat the nail? If I treat the ganglion cyst? And so the answer to that is that yes, about 75% of patients will actually have improvement in nail dystrophy after the surgery. And so this is a patient who presented with a mucous cyst, and if I got an X-ray, and as you can see, their finger was arthritic, and they had pain associated with this. And so the treatment for that was a DIP fusion. If their fingers are arthritic, they have an osteophyte, and it's not painful, then it would be a osteophyte debridement, not a fusion. Now, the other variety that we see mallet fingers much more common than jersey fingers, except that the reason I present jersey fingers is that those tend to be a surgical urgency for us. And so the patients will present typically with what we call a jammed finger. And a mallet finger is disruption of the extensor tendon, the terminal tendon of the DIP joint. And so they will present with a bent finger inflection. A jersey finger, on the other hand, which we see very commonly actually during the fall, is a sports-related injury when they forcibly flex the DIP joint and they have avulsion of the flexor digitorum profundus tendon. For mallet fingers, when they present, we also get an X-ray to see if they have what we call a soft tissue mallet, no bony involvement, or a bony mallet where the bone is involved. And so treatment for a soft tissue mallet is splinting. And I just want to show that in this, the type of splint doesn't really matter. I think what really matters is actually not immobilizing the PIP joint, because the PIP joint gets really, really stiff. And so if you do put them in a splint and you want to manage it yourself, make sure that the PIP joint is not involved when you splint this mallet fingers. Bony mallets are a little bit more complicated, and so I will go into more detail about bony mallets in a second. So for non-operative mallet fingers, we splint the DIP joint in extension 24/7, followed by, that's for approximately 6 to 8 weeks, and then we will nighttime splint for additional 4 weeks. Just to go back to this slide, the picture on top, the one that has the white splint, that material is called X-Lite. And the reason I like this splint is that patients can actually shower in it. And so some institutions will have this X-Lite splint. We have it here at UCSF. That's the X-Lite splint. So when would you, if you decide not to refer this mallet fingers, you could treat it. If it's a soft tissue mallet and you're comfortable with splinting, you could treat it yourself. When you have a bony mallet, I think if you're unclear if it's non-operative or operative, I think that's a good time to refer the patient to hand surgery. What we look for in terms of surgical versus non-operative treatment of bony mallet fingers is the size of the fragment, usually something about a third or bigger in terms of articular involvement. We may consider a fixation. And then if you look at example number 2, there is what we call volar subluxation of the distal phalanx, which means that the joint is not congruent. If you leave this untreated, the patients will commonly present with arthritic joint in the future and a painful joint. There is some evidence in adults that even some patients may tolerate this, but this is a conversation to be had in terms of risks and benefits with a hand surgeon. Now, the red flag for us is what we call a jersey finger. And the way you test this is very simple. If someone comes with a jammed finger and it's not a mallet finger, you isolate the DIP joint and have them flex. If they can't flex their DIP joint, then you have to suspect a jersey finger. Sometimes x-rays can be helpful. In this case, you see avulsion of the bone with the flexor digitorum profundus tendon. But sometimes they will not have any bone involvement, and it's still surgical and an urgency for us. And so I would say all jersey fingers should be referred to the hand surgeon as soon as possible and be seen as soon as possible. The next common pathology that we see is trigger fingers and trigger thumb. And this is I would say in my clinic of about 30 patients per week, I would probably see about somewhere between 3 to 5 trigger fingers and thumbs is very, very common. And so what I like to do is when I see my patients in clinic, I actually go on Google and I type out trigger finger, and it kind of gives them a visual representation of what's happening and why they're having pain at the level of the A1 pulley and sometimes at the PIP joint. So basically the way I explain it is there is some mismatch between the pulley and the tendon, and so that's causing some irritation. It's actually not a tendinitis, it's a tendinosis, which is a degenerative process, but then I think that's kind of hard to explain to patients. So I just tell them it's usually some sort of mismatch and inflammatory process. The way they present, they may present with difficulty making a fist. You don't have to have trigger finger, but if they click or they lock, then that's an easy diagnosis to make. Sometimes, actually pretty often, they will present with pain at the level of the PIP joint. And so when they present with that level, when they present with pain at the PIP joint, I actually turn their palm over and I'll push at the level of the A1 pulley. And if they have pain, that for me is usually trigger finger. This occurs more commonly early in the morning when they wake up, or late at night after they're done with their day. On physical exam, you can palpate at the level of the A1 pulley, and as this slide indicates, the level of the A1 pulley is between the distal palmar crease and the digital crease, and on the thumb at the MP joint crease. That's where we palpate for the A1 pulley. Most common causes of trigger finger is primary trigger finger is idiopathic. There are some known associations such as diabetes and amyloidosis that may potentially cause increased incidence of trigger finger. These are pretty uncommon. So what are the treatment modalities? You can try NSAIDs for very early trigger finger, not very symptomatic. But in general, in my hands, NSAIDs don't work as well, especially if they're clicking. If they come to my clinic, I usually go to a corticosteroid injection. But some people are really definitely afraid of needles. And so in those situations, you can try to start with occupational therapy and splinting. And operative release is the final solution in my hands. So what is the data for therapy? So if your patients want to go to therapy for their trigger finger, the prescription is this, differential gliding of FDP and FDS. Basically, you're trying to have them move separately. And so there is some evidence for efficacy for therapy. This study by Salim et al. Showed a 70% efficacy versus close to 100% for corticosteroid at 3 months. If you are going to go the splinting route, this is what you would order, either a PIP or MCP splint to prevent restricted motion of the finger. If I were to go the splinting route, I would probably go with the MCP route. Like I mentioned earlier, the PIP joint, even in mallet fingers, it tends to get really stiff. So my preferred splint would be the MCP splint. The thing about the splinting is that it's not very well tolerated by patients, because in order for it to be efficacious, you actually have to leave it on for 6 weeks, 24/7. So it's kind of like a mallet splint. A lot of patients will tend to take it on and off. And so I think that's why some of the splinting therapies don't work as well, because of compliance. Corticosteroid injections, for the isolated early trigger fingers that present within less than 6 months, first timers who are not diabetics, usually efficacy is around 70%. I usually quote a 50% efficacy for everyone, just to make the number easy to remember. And I'd say the first injection there's like a 50% efficacy, and if that fails, the second injection is also a 50% efficacy. But then there is documented lower success rate in patients who are diabetics, who have multiple trigger fingers and other upper extremity tendinopathies. In diabetics, sometimes I do offer surgery after a single injection, because I know they have closer to a 30% efficacy rate. So if you are going to inject a trigger finger, this is a very easy injection to do. It can be somewhat painful for the patient, and the way I describe it to patients, it feels like a bee sting. And I've modified my technique to make it as less painful as possible. And so I will discuss some of those points. The key, I feel, to injecting a trigger finger is that you use the smallest needle possible. So a 27 gauge, our smallest needle is a 27 gauge needle. And once you once you go through the skin, I describe that as a bee sting. I inject a small aliquot of the lidocaine and canalog mix and let the lidocaine take effect. And then I inject very slowly over 30 seconds. And so that essentially makes it painless after that first entry of the needle and the little burning sensation they'll feel from the lidocaine. The faster you go, you're going to have hydrodissection of the tissue, and that's going to be really, really painful. And so just go slow, small needle, and go slow. Another question is, do I use a spray? I don't use a spray. We've actually have studies from the Journal of Hand, published in the Journal of Hand Surgery that does not show any benefit of using the spray when injecting, but I think that's dealer's choice. Maybe some patients ask for it, and I do give it to them if they want it. In diabetics, I counsel that their blood sugar will increase with the greatest effect in the next 24 to 48 hours to up to 150% of their baseline. And then this may last up to 5 days. This is especially important to talk to for patients who are insulin dependent. So surgical indications are failure of non-surgical treatment. And then another thing I want to highlight is that if the patient presents with a locked finger and they can't unlock it in clinic, sometimes I will, depending on how painful it is for them, sometimes I may inject it and try to, with just plain lidocaine, and try to unlock it for them. But if I can't unlock it, that for me is like a surgical, it's a surgical indication. So the surgical treatment is a 1 centimeter incision, takes about 7 minutes, and we release the A1 pulley. The next topic I want to discuss is thumb CMC arthritis, which is also known as the basal joint. So you might hear CMC arthritis or basal joint, that's usually the thumb. And so the patients might present with difficulty pinching, opening a tight jar, holding a steak knife or a fork to cut. They also present with complaints of having some feelings of soreness at the base of their thumb and their first web space as well. On physical exam findings on advanced cases, you might have something called a shoulder sign, which is due to dorsolateral subluxation of the thumb CMC joint, such as in this case. And some patients will also have hyperextension of the MP joint. So specific tests that we use is called, there are 4, the grind test, the adduction stress test, extension test, and the metacarpal compression test, which I will go over. And what you might find in some pictorials is how to do a grind test is basically you hold a thumb and you grind it side to side, and then you're trying to grind the CMC joint. I wanted to illustrate this graphic because if you look at the patient's, the examiner's hand, they're actually holding the thumb distal to the MP joint. The problem with that is that some patients will have arthritis of the MP joint, and so they will have pain. It may not be the CMC joint, it might actually be the MP joint that's causing pain. And so it's hard to tell with a grind test where the pain is coming from. So I rarely do the grind test, but when I do the grind test, I actually hold proximal to the MP joint to do a CMC grind. These are some of my favorite tests: the adduction test, the extension stress test, and the metacarpal compression test. The sensitivity for the adduction and the extension stress testing is 93% for CMC arthritis. There is no reported sensitivity for the metacarpal stress test, but in my hands, it tends to work really well. So basically, when you're basically, it's like a more direct grind test of the base of the CMC joint. Treatment options for this is, I usually start with non-operative treatment. And so that in my hands is either a injection or a splint. There are off-the-shelf splints that you can use. The one that we tend to like and prescribe here at UCSF is the Push Meta Grip. It's a little more, it's a basically like a plastic-based splint that is not as restrictive, and then patients tend to tolerate it well. The downside of this is that it's not covered by insurance, and it costs about $80 if you go online. Medicare does tend to reimburse for the Push Meta Grip. For therapy, you can also ask for a CMC protection program, which they usually help guide the patients in terms of using adaptive equipment and symptom management for CMC arthritis. When I do inject patients, when they do ask for it, I've had, sometimes it works up to a year, sometimes it works 2 weeks. It's kind of hard to tell how long it will benefit the patients, but I usually tell them it tends to be a Band-Aid. It does not resolve it, it will come back. This injection is not as hard as people think it is. I think people, even our trainees, kind of feel intimidated by this injection. And I'll sort of explain how I inject it, which makes it easy. So the key is to palpate the CMC joint. So if you take the thumb and you use your fingernail and you go proximal down the metacarpal, there will be a spot where you just kind of fall in, So if you take your finger and you go down your metacarpal, it'll just kind of fall in. And I usually mark that with my fingernail, so I have a spot there. After that, I will prep the skin, and I will do a small aliquot, about 0.5 cc of lidocaine, and that tends to numb the skin and the deeper soft tissue. And that, for me, has been a game changer in terms of pain, patient satisfaction, in terms of pain, in terms of my injection. After I do a small aliquot with the 0.5 cc's, I go in deeper with a needle. And I think where people sometimes get into trouble is when they go straight down with the injection. It's kind of hard to find the joint, especially in the arthritic joint. And so the way I do this is I will actually pull on the finger to distract the joint, and then I come in at an oblique angle. So once I come in with an oblique angle, I will hit the base of the metacarpal and I'll slide down. I usually go in about 1 centimeter. I will aspirate just to make sure I have like an air bubble to check if I'm in the joint. And then I will slowly inject my solution, which is about 10 milligrams of kenolog and a 1 cc lidocaine mix. The key to this injection is that it's actually patient pain, because when you inject and the patient starts having pain, that actually tells you you're in the joint, because the capsule distends. And oftentimes the max I could inject is 1 cc. So I'm not trying to push all 2 cc's. It's 1 cc is usually the max. Surgical treatment for this ranges from fusion to CMC arthroplasty. Most of us do something called a trapeziectomy, and I was kind of vague on what I put in. It's called something else because it doesn't really matter what you put in there after you do a trapeziectomy, which tendon you put in. They all tend to do the same. All right, next one is Quervain's tenosynovitis. Patients present with radiosciatic wrist pain. This is tendinosis of the first dorsal compartment tendons. I call them the Appleby tendons, APL and APB, the Appleby tendons. And basically what happens is that the fibrous sheath over the first dorsal compartment is usually paper thin, and with repeated irritation, and sometimes I have the thickest Quervains I've released was 1 centimeter thick. And they usually present with a complaint of a painful wrist and also a bone growth. That's what they think it is, but it's actually the sheath, the hypertrophies. Pain is on the radial side, is worse with repetitive activities such as lifting. And then usually mothers with very young children tend to get this. It's more common in women, and like I mentioned before, it often occurs in new mothers or in late stages of pregnancy. I've also seen this in fathers with newborns, and the reason I joke and I said, I usually say it's because the babies double in size every week. The pain is on the thumb base or the radial wrist, and if it's really severe, sometimes they might present with clunking of the thumb. So the test that we are all taught in medical school is the Finkelstein's test. And so I kind of wanted to point this out that a lot of times we were taught to, put the thumb, adduct the thumb, put the fingers over the thumb, and the examiner takes the finger and ulnarly deviates, and we call that the Finkelstein's test. But that's actually a misnomer. That's actually the Eichhoff test. And so I made this slide showing what the Finkelstein's test is. So this is with an open palm. The patient ulnarly deviates, and we grab the thumb and adduct it. That is the Finkelstein's test as described by Dr. Finkelstein. And this is the Eichhoff test. Okay, so which one is better? So there was a study looking at asymptomatic patients comparing ICOF test versus Finkelstein's test, and what they're looking was for false positives. And so the specificity of Finkelstein's test was 100%, ICOF test was 84%. So Finkelstein's test is actually better in terms of false positives. So treatment for Quervain tenosynovitis is initially non-operative. And so you could try splinting, either a off-the-shelf or prefab. This is how I actually treated my wife when she had Quervains. And then that worked for her, but then sometimes it doesn't work, or they are in a lot of pain. And if they come to my clinic with a lot of pain, then I will recommend a corticosteroid injection. And what I quote is it may take up to 2 injections with a 80% success rate. One thing about Quervain's injections is that it's very superficial, and if you don't get into the sheath, depending on the steroid you use, there is a higher risk of depigmentation than like a trigger finger per se. I think the key to injecting for Quervains is to use a water-soluble steroid, such as dexamethasone. So if you're not quite sure if it's soluble or not soluble, if you look at the bio, if it says something like sodium phosphate in the name, that's usually soluble. And then if you have something like acetate, that's usually insoluble. I do a 1-to-1 mix of steroid and lidocaine. What I've also do here when I inject Quervains, I do use a 0.5 cc aliquot of lidocaine before I go in deeper with a needle, and that has been also like a game changer in terms of patient pain relief and satisfaction when I inject. You can inject straight down over the A1, over the first dorsal compartment, or I like to go in an oblique angle. A special note about pregnancy and lactation is that it tends to work really well for patients who have Quervain secondary to after pregnancy or when they're pregnant. There's anecdotal reports of decreased lactation after steroid injection, which I counsel patients about. We actually try to do this study here at UCSF, but it's been very difficult to actually design it. Surgical treatment for Quervain surgery, if it fails non-operative treatment, is to divide the fibroosseous tunnel. Next is Dupuytren's contracture, which we call Viking's disease. It's a fibroproliferative disorder, autosomal dominant with variable penetrance, usually associated with patients with Eastern European and Northern European descent, also seen in higher incidence with patients who are diabetics and heavy alcohol use. So patients usually present early on. If they do present, they present with a nodule in the palm. And the question I get very often is this going to get worse? And this is what I usually quote. I'd say that about 10% of the nodules will go away, 90% are here to stay. And of those 90%, half of them will develop a contracture by 9 years. But only 15% of those will meet criteria for surgery. And this is based on only one study, a very old study. And so there's not really great natural history on Dupuytren's. On physical exam, they may have either a nodule or they have a cord, and the cord may or may not be associated with finger contracture if either the MP joint or PIP joint. So after I counsel the patients, if they're not advanced and we don't talk about surgery, the test that I like is called the Houston tabletop test. It's basically can you put your palm flat on a flat surface? And if you can, I usually say, okay, if you're able to do that, I would not recommend a surgical intervention. And I tell them, use this test. If you're not able to put your palm flat on a test, then that's when you come back and see me. Treatment for this is for nodules, you can actually do corticosteroid injections. It does take multiple corticosteroid injections, but it has been shown some efficacy for nodules. There is a question that we sometimes get about radiation therapy for nodules. Does it prevent contractures? The jury is not out on this. There's a lot more literature in the European literature of using radiation therapy for early Dupuytren's, but I don't think evidence, in my opinion, supports the routine use radiation therapy for Dupuytren's. You can use something called collagenase, which is an enzymatic fasciectomy. It has not shown increased efficacy compared to percutaneous needle aponeurotomy. It actually does cost more. And surgical treatment is a partial fasciectomy, which is removing the diseased cord. So the classic teaching is for what is the indication for intervention is any PIP contracture or 30 degrees of MP contracture. Next, we're going to talk about ganglion cysts, dorsal and volar. So dorsal ganglion cysts are much more common than volar ganglion cysts. You could try to illuminate this with a light and then to see if it's a ganglion cyst. I would not recommend using your iPhone light. That tends to be too strong. Even solid masses look like they're illuminating with those. So I don't use my iPhone light for this. Dorsal ganglion cysts are much more common than volar. But if you can see, a lot of times the patients look at their wrist and they're like, "Oh, is this a cancer?" That's the question. Is this cancer? And a lot of times you could just by how mobile it is, if it illuminates, you can counsel them and say this is a ganglion cyst. And if they're painless, I usually recommend you could just watch it because unless they want to trade a bump for a scar, that's what I recommend. But if they do have pain with terminal end range of motion, such as inflection or extension, then that's when I recommend surgery. Some patients will present with wrist pain, especially dorsally, and they don't have a mass. In my differential diagnosis, a lot of them have what's called the occult ganglion cyst, which tends to be painful because they're sort of trapped. It's like a pressure phenomenon. For those patients that get an MRI, and if an MRI shows the occult ganglion cyst, I tend to offer surgical intervention for those. What is the recurrence rates with aspiration of the dorsal ganglion cyst? It's pretty high, so I usually don't aspirate the dorsal ganglion cyst unless they're really ask me to. They really want it aspirated. Surgical recurrence risk in my hands for dorsal ganglion cysts is about 4%, which is supported in the literature. So for volar ganglion cysts, I usually don't recommend. For dorsal ganglion cysts, I will aspirate with the ASPI. For volar ganglion cysts, I usually don't because the radial artery is in close proximity, and sometimes you could have a pseudoaneurysm of the radial artery, and so I do not aspirate volar ganglion cysts. There is a higher recurrence risk with surgery with volar ganglion cyst excisions. Next, we're going to go to carpal tunnel syndrome. I think this is pretty familiar for everyone, so I'm going to briefly discuss this. Numbness in the radial 3.5 distributions of the palmar hand. And so, what patients complain about is that they wake up at nighttime and they have to shake their hand. There's actually a name for that. It's called the shake sign. They present with the hand goes numb whenever they put in either flexion or extension. In our case, these days is using the phone or driving. When we sleep, we tend to actually flex because our flexors are stronger than our extensors. So when we tend to sleep, we tend to curl up our elbows and flex our wrists. That's why they wake up with compression of their median nerve. Usually it's not associated with pain, but then some patients will describe it as a painful sensation. And so it does not rule out carpal tunnel syndrome, but it can be present in carpal tunnel syndrome. In late stages, you will have weakness and then clumsiness, and then sometimes they can't button their shirt because they can't feel the buttons. The motor anatomy for the median nerve is the off muscles and the thenar eminence. So most of the muscles, except the deep head of the FPB the deep head of the flexor pulsus brevis is median nerve innervated. So the off muscles, and this is important because when you're testing, the muscle that we tend to test is the abductor pulsus brevis because it's a superficial muscle and easier to test. And the way I explain patients when I'm doing this test is I ask them to make for example, I make a number 7 like this, or L, I guess, as Lee in my case. And then, so basically it's a palmar abduction of the thumb, and then you have them resist. And the APB is, if you feel your metacarpal, is the first muscle radial to the metacarpal. That's APB muscle, which is illustrated in this pictorial. sensitivity for tenosyne is about 40%. And this is the phalanx test. In medical school, I was taught to do the phalanx test like this with the elbows flexed, but the actual phalanx test is described with the elbow extended. The test that I really like is the Durkin's carpal compression test, which has the highest sensitivity for carpal tunnel syndrome. So these are the provocative tests. So the median nerve is radial, it is radial to the palmaris longus tendon, and that's where I tap. And that's the Durkin's compression test, and this is the phalanx test with the elbow extended. I'm going to show you guys a test called the scratch collapse test. It doesn't work all the time, but when it works, it's actually a pretty good party trick. Basically, it works for any compression neuropathies, carpal tunnel, cubital tunnels, thoracic outlet syndrome. And what it tests is tonic external rotation of the shoulder. So basically, what you do is you have to make sure that the patient doesn't have shoulder pain, shoulder issues, but you have them put the arms to the side and then resist with external rotation while you try to internally rotate their shoulder. And you do that after you sort of scratch that area of compression. So this is the scratch collapse test. So that's for carpal tunnel syndrome. And when it's positive, they will lose their sort of resistance to external rotation. So the question is, how does it work? We don't really, the theory behind it is that it's some sort of sympathetic reflex arc that actually basically the thought behind it is when you have like a noxious stimuli, your body will sort of lose its tonic ability to contract to painful stimuli. This is not painful, but then that's basically the thought behind the scratch collapse test. Another question that I get is that do I need to get an EMG? So this study compared using EMG in terms of sensitivity and specificity versus just physical exam findings and history. And this is the CTS-6. And from this study, we know that if you have a score of more than 12, this is positive for carpal tunnel syndrome. This is something that we use in clinic as well. But in general, we do get a nerve conduction study just to get a baseline in case we have to go back for a revision. So we'd like to know if there's an improvement or worsening of function with an EMG, which we follow objectively. Non-surgical treatment for us is nighttime bracing and the occupational therapy for nerve glides. I rarely do corticosteroid injections except for women that are pregnant, which tends to work really well. But when I do corticosteroid injections as first-line treatment for carpal tunnel syndrome, I do it for specific reasons. It is therapeutic for about 80% of patients with symptom improvement at 6 weeks, but only 20% are symptom-free at 12 months, so it doesn't last long. It does help for diagnostic purposes when you're not quite sure if it's carpal tunnel syndrome. Maybe there's a component of cervical radiculopathy. Then I may inject carpal tunnel syndrome, or if their whole hand is numb. And so I want to see what proportion of that is due to carpal tunnel syndrome, then I may inject. But it's also prognostic that if I do a carpal tunnel injection and 93% of those improve with the injection, if I do a carpal tunnel injection and they improve it after the injection, then I could tell them that 93% of patients will improve after the injection. If they don't improve after the injection, then I tell them it's 50-50. This injection tends to be a little more tricky than like a trigger finger or Quervains. I would caution you that this is probably better learned after you observe someone do it. Just have to know where the median nerve is. The median nerve is radial to the palmaris longus tendon. And the way you find the palmaris longus tendon is you have them take the thumb and the pinky, oppose it and flex it, and you'll find the palmaris longus tendon. When you go in initially, just make sure you go in really slowly, and if they have paresthesias in their finger, then you may have to redirect the needle. Make sure you don't inject if they have paresthesias on the finger. That will kill the nerve. surgery for us is release of the transverse carpal ligament. One thing that has come out recently is the association with carpal tunnel syndrome with amyloidosis. And so this study came out of Cleveland Clinic looking at incidence of amyloidosis and then sort of distilled as to who should get a biopsy. And so it's usually male age, patients with bilateral carpal tunnel syndromes, male age greater than 50 years old, female age greater than 60 years old. And then if they have some sort of associated pathology, such as cardiac issues or low back pain or biceps tendon ruptures, the incidence of carpal tunnel syndrome using this diagnostic criteria is about 10%. I do have to caution that in this paper, every patient actually in this paper were Caucasian. So there's this data that may not apply to different races. Now to elbow pathologies, I'm gonna finish my talk by talking about cubital tunnel syndrome and lateral epicondylitis. This is very common things that we see in clinic. So cubital tunnel syndrome is compression of the ulnar nerve over at the level of the elbow. They will present with numbness in the small finger and the ring finger. It doesn't have to be both, sometimes it's one. Some patients will also complain of soreness in the elbow. They may not have numbness. They may have soreness in the elbow. And this is especially true in patients who have distal humerus fractures, that they may actually have compression of the nerve. They may not have numbness, but they have this persistent soreness in the proximal forearm. In terms of motor innervation, the ulnar nerve innervates most of the intrinsic muscles of the hand, but also the flexor digitorum profundus to the small finger and ring finger. And there are special tests such as the Frommans and Wardenbergs, which I will demonstrate. So my cubital tunnel exam, I will palpate my landmarks such as a medial epicondyle, the location of the ulnar nerve, and I'll do a Tinels. You may elicit a better Tinels if you flex the elbow and do the Tinels as well. This is an elbow hyperflexion test, which I hold for up to a minute, and once their finger, pinky or their ring finger starts getting numb, that's a positive test for elbow hyperflexion test. I do have cubital tunnel, and I just held it for 5 seconds, and my finger went numb. In terms of ulnar innervated muscle testing, I do test flexor digitorum profundus to the small and ring finger, like that. And I've actually modified my test, which I will show in the live exam, which is, I feel it's a better test to test FDP. And then the first dorsal interossei, which is where I palpated with my left index finger. In terms of intrinsic muscle testing, we also test the palmar and dorsal interossei. In medical school, we're taught PAD and DAB, and then cross finger adduction, which is intrinsic muscle. The first dorsal interossei again. Okay. And I included the slides for your records. Okay. Frommans sign is basically we're testing key pinch, and usually when you use key pinch, you use your adductor pollicis. But in patients who have a weak adductor pollicis because of ulnar nerve problems, they will compensate by flexing the thumb, which is FPL, flexor pollicis longus, which is a median innervated muscle. This is a normal key pinch. And this is a positive Frommans test is when you actually bend the IP joint. In reality, a lot of patients will slightly bend the IP joint when they do the Frommans testing. Wardenberg's test is when the patients have ulnar deviation of the small fingers and they can't adduct, they can't bring their pinky in or they can't hold it in because the EDM is has an ulnar vector, so it actually tends to bring your finger out. So that's the extensor tendon that tends to bring the finger out. So this is the Frommans sign. That's a negative Frommans, and this would be this is a positive Frommans test when they bend their IP joint, and they can't hold the piece of paper. And in order to hold, they were actually really squeezed down by bending their IP joint. And once again, the Wardenberg's sign. So they can't keep their pinky in, or they can't bring it in. And here, once again, the scratch collapse test. You could lightly scratch over the cubital tunnel and test it. I would say the sensitivity of this test, when it was first described, it was somewhere around 65% by the author, and it's been reproduced to approximately 30 to 40%. So it's not that great, but it's actually fun to do. Non-operative treatment for this, patients with cubital tunnel syndrome, you do the elbow hyperflexion test to compress the ulnar nerve. And so what you want to avoid them doing when they're sleeping is to actually hyperflex their elbow. And what we usually recommend is actually a knee pad called a heel bow. And we have them buy a knee pad and then turn it over, and so it helps them not compress the elbow. Or you could use a stack of towels to wrap it like this. Operative management, there are different ways to treat this, okay, which I think is beyond the scope of this talk. In terms of lateral epicondylitis, tennis elbow is one of the most common overuse syndromes encountered in the upper extremity. I would probably see about 3 to 5 lateral epicondylitis patients in my practice every week. So what the patients will present with is elbow pain, they have problems gripping. It could be, and then it's actually quite annoying because it's actually a persistent pain. They have weakness of grip. Sometimes it may be worse at nighttime. It's so bad that sometimes they can't even shave or even pick up a cup of coffee. It always involves the extensor carpi radialis brevis tendon, which is a wrist extensor that inserts at the middle metacarpal, the third metacarpal, which is the basis of one of our exams. So on physical exam, the tenderness is not usually exactly at the lateral epicondylitis. It tends to be about 1 centimeter or 2 distal and anterior. And we will test for resisted wrist extension or the long finger, the middle finger extension, which I will demonstrate in a video. So that's the medial epicondyle, slightly distal, slightly anterior. And I test for resisted wrist extension. That's called the Cousins test. And the Maudsley's test is resisted middle finger extension. Some patients might have pain, about 4 to 5 centimeters distal to the epicondyle anterior. And in those patients, they might have something called the radial tunnel syndrome. So in terms of management, you usually counsel them on activity modification. If it hurts, stop doing it. And I usually tell them that it may take somewhere between 6 months to a year to get better. The good news is that even without treatment, about 80% of patients will get better somewhere between 6 to 8 months. The problem is the patients who do have symptoms the 20% that do have symptoms past 1 year or even 6 months. For those patients, I usually recommend starting with therapy, with directed therapy. And so I ask for something called Mills, passive stretches, and also inertial exercises, which is eccentric muscle strengthening. Inertial, spelled NIRSCHL. We can try to use something called a counterforce brace or a wrist cock-up splint. And the efficacy of this bracing has not borne out. But then patients do tend to like it. The problem with the counterforce brace is that sometimes you have to make it so tight that to be efficacious. And I usually counsel them, if you make it too tight and your fingers are going numb, then you need to loosen it up. The reason why we use a wrist splint is because of ECRB is a wrist extensor. So by relaxing wrist extension, you may actually offload the ECRB. This is the inertial exercises, which is basically eccentric muscle strengthening. And there is, I guess, mild to moderate evidence that this helps for tennis elbow. Other treatment options that I want to discuss briefly is corticosteroid injection, PRP. ultrasound guided percutaneous needle tenotomy and surgery. And so one of the frustrating things about tennis elbow is that it lasts for a long time, and the efficacy of our treatments are not they're not great. I'm gonna start with corticosteroid injections just to, I know there's people still out there injecting corticosteroids, but I think in our hands, at least at UCSF, is that corticosteroid injections as of 2022 is that there's no efficacy of corticosteroid injection compared to saline. PRP, depending on what you read, the most recent systematic review and meta-analysis showed that there is no efficacy of PRP, but there is evidence out there that shows that PRP does help. And so the downside of using PRP, in my opinion, is that a lot of insurances don't cover it and it's cash pay. There's also something called a percutaneous needle tenotomy or TENX procedure, basically using a high-frequency needle and then sort of aspirating and taking out the diseased tissue. There is studies supporting this. There's no randomized control study yet out there comparing this with saline, but it does show to have some efficacy around 80%. And just a plug for one of my partners, Dr. Bill Bergen, who just joined our practice, he does offer this. The good thing about this is that it tends to be covered by insurance for our patients. So finally, I'm a surgeon, and so I love surgery, and so this is what we call the inertial procedure, which is this debridement of the ECRV tendon. The problem with the inertial procedure is that there was a study, the randomized control study that came out looking at this, and we also found that it has no benefit over sham surgery. So it's very frustrating for us because sometimes we don't have much to offer our patients. So in summary, for tennis elbow, I think there is mild to moderate evidence that therapy helps. 80% of patients will get better even with nothing. That you could, if they failed therapy in my algorithm, I could offer after therapy, I would actually go to the TENX procedure or PRP, and I just counsel them about the insurance issues and then see if they recover from that. The last resort in my hand is the inertial procedure, and I tell them that it actually has no benefit over sham surgery, but some patients still elect to do it. Thank you. And this is my email in case you have any questions.